Welcome to the deep dive. Just a quick transparency note before we start. This deep dive is based on a clinician-written article from Mentalyc, brought to life in audio with help from AI for therapists who prefer listening on the go.
So today we are diving deep into something that's maybe not the most glamorous part of our job, but it's absolutely critical.
Documentation.
Documentation.
Yeah.
Specifically, we're looking at the DARP format. I think we've all had that moment. You wrap up a really complex, high-emotion session. Maybe it's a crisis assessment or a major breakthrough.
Oh, absolutely.
And then you turn to your computer and you're just facing that silent tyranny of the electronic health record.
Yep.
And you're thinking, okay, I have to capture that nuance. I have to prove medical necessity and I have to do it quickly. I mean, the documentation burden is real. We're not just writing notes.
No, we're building a legal, clinical, and financial narrative.
Right.
And that narrative needs a solid structure.
And that's exactly why formats like DARP are so essential for us as licensed professionals. So our mission here is to quickly unpack what DARP stands for: data, assessment, response, and plan. But, more importantly, to really dissect the specific clinical advantages it offers.
Okay, so what's the key insight here? What makes DARP stand out?
The main thing that really elevates DARP, the real differentiating clinical advantage, is the explicit requirement of the R section, the response.
The response.
Exactly. Lots of documentation structures. They cover the what happened, that's the data, and the why it matters, the assessment. But DARP forces you to document the client's immediate verifiable reaction to your interventions.
So it's not just what I did, but how they reacted to what I did.
Yeah, precisely. It's the evidence trail for efficacy. It shows how the client actually metabolized the work, which is, crucial for proving the value of what we do.
Okay, let's unpack that structure then. Let's start at the ground floor with D data. We hear this term everywhere, but in a DARP note, what exactly is clinically relevant data?
So data is the foundation, and it has to be purely factual. It's a mix of subjective and objective information. Subjective is what the client shares with you: their feelings, their symptoms, life events.
And you want to use their own words, right?
As much as possible. It's critical. So for instance, you'd quote the client, "I've been feeling really down and haven't left the house since Tuesday." That's powerful data.
Okay, and then the objective part, that's what I'm seeing.
Exactly. Objective data is what you, the clinician, observe in the room. Their affect, their body posture, behavioral things. Did the client cry? Were they pacing? Did they maintain eye contact? The rule here is super strict. Data is only what was said and what was seen, period.
I know for a lot of clinicians, especially when you're deep in relational work, remembering those exact quotes for the data section can be really tough. I mean, especially at the end of a long day of back-to-back sessions.
It is a real challenge.
Yeah.
But that specificity is exactly what protects you in an audit or a legal review.
So instead of just writing client-recorded stress...
Right, you'd want something more precise, like client reported feeling on edge, like a spring ready to break. See how that shows the severity and the client's internal state so much more clearly.
It does. It's much more vivid. So let's talk about the legal side of this for a second. Why is that factual detail so non-negotiable?
Because it separates the evidence from your interpretation. If an insurance company denies a claim, or if your records get subpoenaed, the data section is the unvarnished truth.
So if I write, "The client was hostile," that's my interpretation.
That's interpretation. You've already jumped to assessment. But if you write, "The client clenched their fists, refused to look at me, and stated, 'I don't want to talk about that again," that is factual data. That shift protects the integrity of your clinical work.
Which brings us perfectly to A, assessment. So this is where our clinical expertise finally comes into play, right? Interpreting the data.
This is the so what section. This is where you take those raw facts from the data and you articulate what they mean clinically. You're assessing progress, emerging problems, risk factors, patterns.
And you have to connect it back to the treatment plan.
You must. You have to connect the session content back to the medical necessity for continued treatment, which is always rooted in their diagnosis and their measurable goals.
Okay, so let's use our earlier example. The data showed the client felt on edge and was clenching their fists. What would the assessment sound like?
The assessment might say something like, "Client continues to exhibit high levels of anxiety, manifesting as somatic complaints and emotional rigidity. This pattern suggests the need to increase coping skills training, which is impeding progress toward goal 2, stress management."
I see. So you're interpreting the link between the facts and the clinical path forward.
Exactly. You're showing your work.
I've seen a lot of clinicians, especially earlier in their careers, struggle to keep these two separate. So let me try to confuse them for a second.
Go for it.
If the client reports having trouble sleeping, and I write in the data section, client reported trouble sleeping consistent with JD symptoms, is that right?
That is precisely the mistake we're trying to avoid. The moment you added consistent with JD symptoms, you cross the line from data into assessment.
Ah,
The data should only be client reported difficulty initiating and maintaining sleep, averaging 4 hours per night. The link to JD belongs exclusively in the assessment section. That's where you use your diagnostic reasoning.
okay, that's a really clear distinction.
And the assessment has to show a clear progression of thought. So if you're treating, say, co-occurring substance use and anxiety, your assessment has to interpret the data through both of those lenses.
Got it.
Something like increased anxiety symptoms this week. Data may correlate with reported relapse trigger exposure. Continued stabilization work is required. The assessment integrates the whole clinical picture.
Okay, now we're at the heart of DARP, the big differentiator, R for response.
Yeah.
If the assessment already shows if the client is progressing, why do we need a whole separate section for response? Can I just say, client seemed engaged in the assessment?
You could, but you'd be significantly weakening your evidence base. DARP forces you to be specific about the effectiveness of your interventions.
So this is the immediate impact.
Yes, the immediate impact of the therapeutic process. If we use CBT or psychodynamic exploration or a trauma technique, the response section is where you record the client's reaction to that specific action. It moves beyond just general engagement to a measurable clinical reaction.
Can you give us a few examples, like for different intervention styles?
Sure. So if you're using a cognitive behavioral intervention, the response should show a cognitive shift. For example, client initially defended the negative core belief, but after examining the evidence, client stated, I guess it's less about being a failure and more about being overwhelmed.
Okay, that's a measurable cognitive response.
Exactly. Or if you're using more of an emotional intervention like emotional regulation, the response would track an effective change.
So like a SUD's rating.
Perfect example. Client stated anxiety level decreased from 8 out of 10 to 5 out of 10 following the grounding exercise. Client maintained a calmer posture for the rest of the session.
That is the gold standard for medical necessity. You're showing that direct link between the paid service, the intervention, and measurable positive outcome right there in the session.
It is, especially for audits.
Yeah.
And think about psychodynamic or insight-oriented work. The response is more subtle there, right? So you might document a relational or an insight response. Like, when challenged about patterns of self-sabotage, client was initially defensive but later expressed, I think I realize now that I push people away before they can hurt me. This represents significant insight.
Wow, that level of detail really proves the work isn't just talking. It's guided, purposeful, and effective.
Or it reveals that the approach needs to be modified. Without that R, the note is really incomplete.
That brings us to the final piece, P, the plan. We've got the facts, we've interpreted them, we've documented the reaction. Now, where do we go from here?
The plan ensures continuity. It sets clear expectations for the time between sessions, and it has to align with the overall treatment goals. This isn't just a list of homework.
It's a blueprint.
It's a blueprint for the next phase of treatment, exactly. Key things to include are the intended focus for the next session, maybe continue exposure hierarchy preparation. Client homework needs to be specific and measurable, like practice the 5-4-3-2-1 technique twice daily and record triggers.
And we also need to document our own planned actions as the therapist, right?
Absolutely.
Yeah.
This would include planned interventions for next time, like initiating a formal EMDR protocol, or maybe consulting with a psychiatrist for a med review. And don't forget, coordination of care. If you're referring out or consulting with a supervisor, that goes here. It maintains a complete record.
You know, hearing you describe all that, documenting all those specific D, A, R, and P elements, making sure every section is clinically useful, factually grounded, it's incredibly cognitively demanding.
It is, especially after a taxing session.
If that documentation process hits home and you feel that time pressure to capture these specific crucial details for compliant formats like DARP, Mentalyc can help. Its AI note taker automatically drafts your notes and treatment plans from sessions and is fully HIPAA and SOC2 compliant. You can try it at Mentalyc.com.
Moving beyond just the structure, it helps to contextualize DARP by comparing it to some of the other common formats out there. It often clarifies why a clinician might choose one over another.
Okay, so let's start with the classic. So P, subjective, objective, assessment, plan. How does DARP stack up against it?
Well, a SOP is structured pretty similarly, but the key difference is in how it handles the data and the response. Both splits subjective and objective data into two separate sections. DARP merges them into one comprehensive data section.
Okay.
But more crucially, the client's response to interventions is often kind of hidden in a SOAP note. It gets rolled into the assessment, which makes it vague, or it gets buried in the plan.
I see. So DARP makes it explicit.
It forces it into the open. In a SOAP note, you might write, client reported feeling better and agreed to homework in your assessment. But in a DARP note, you have that dedicated R section that says, following diaphragmatic breathing instruction, client reported a subjective improvement from a level 7 distress to a level 4. DARP forces that measurable efficacy that SOAP lets you gloss over.
That makes the R invaluable for insurance appeals, I'd imagine, when you need explicit proof.
Definitely.
What about BR? Behavior Intervention Response Plan? That one seems even closer to DARP since it already has a dedicated R.
It is close, and it's an excellent detail format, but its structure is a little different. BRP puts a heavy emphasis on separating the actual intervention into its own category. So you list what you did, then how the client reacted.
Whereas DARP implies the intervention.
Right. In DARP, the intervention is implied within the assessment, which is your rationale for doing it, or within the response, which is the reaction to it. For some clinicians, DARP feels a bit more streamlined because it focuses more on the client's experience, the data, assessment, and response, and less on the therapist's detailed activity log.
That's a good way to put it. Okay, so understanding the format is one thing, but execution is another. What are some of the big mistakes even experienced clinicians make with DARP that could compromise compliance?
Well, beyond the classic DA confusion, a huge one is a lack of symptom specificity in the data. Clinicians often write anxious or depressed. That's not enough.
You need the functional impairment.
You have to document the functional impairments.
Yeah.
Missed work twice this week reports persistent anhedonia and early morning awakening. That's the stuff that demonstrates medical necessity.
And what about the assessment section? I see errors there too.
Yes, the big one is the failure to link the assessment directly to the stated treatment goals. If the client's goal is reducing relationship conflict, but your assessment is all about generalized anxiety without connecting the two, the note looks disjointed. It weakens the argument that the therapy is actually goal-directed.
Okay, and the R section, the one we keep saying is the most important. What's the common mistake there?
Vague efficacy reporting. It's the difference between writing client reported feeling better and client reported the ability to use the taught grounding technique to de-escalate 2 episodes of panic over the weekend. If the efficacy is vague, the intervention might look unjustified. That's a huge red flag in an audit. And maybe 2 final quick ones. Ignoring risk factors outside of a crisis. If a client reports increased hopelessness, that has to be in your assessment and reflected in the plan. And second, just copy-pasting the plan from week to week. The plan has to be a living document. It has to show it's being modified based on the response from the session.
That dynamic aspect is so crucial, isn't it? The consistency that DARP provides, making sure you cover the facts, your interpretation, the client's reaction in the plan. It really elevates documentation from just being paperwork to being an essential clinical tool.
It really does, and you have to write those notes as soon as you can. That immediacy is what lets you capture the exact quotes, the subtle reactions, and the specific numbers you need to make the note compliant and clinically robust.
And that immediate capture of detail is where the time crunch always hits the hardest. We know the most crucial part of DARP is documenting the client's response, the R, which often relies on subjective reports and our own observations. So if the clinical relationship is the core engine of change, how much more potent and frankly clinically robust could your documentation become if technology could help verify and flag those subtle nonverbal alliance signals that you might miss while you're focused on delivering an intervention? The article mentioned the Alliance Genie feature, which is designed to do just that.
That's a fascinating thought.
That ability to capture the real nuance of the R section, that is definitely something worth mulling over. If mastering structured documentation and saving valuable time is your goal, check out Mentalyc. Their AI note-taker and specialized tools like the AI Treatment Planner and Alliance Genie are designed to capture the detailed elements needed for compliant formats like DARP, reducing documentation stress so you can focus on client care. Find out more at Mentalyc.com.